Welcome, everybody. I think we're going to get started. I'd like to welcome you to the Johnson-Shoyama Graduate School of Public Policy's second annual Houston Lecture. My name is Kara McDavid, and I'll be emceeing tonight's event. As somebody who has worked within mental health and addictions, I'm really looking forward to this evening's talk. I'm currently an MHA student within the Johnson-Shoyama Graduate School of Public Policy, and I know that the issue of providing responsible, accessible care is a significant issue. We need to think about how to collaboratively best meet the needs of persons who are living with mental health and addictions concerns. As we come together tonight in the Health Services Theatre, we acknowledge that we are on Treaty 6 territory and the homeland of the Métis. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with each other. In addition to the many individuals here tonight from the community, I would like to welcome my fellow students and faculty from our school's University of Regina campus. It's situated on Treaty 4 territory. And I would also like to acknowledge a few key individuals who have joined us tonight. Dr. Stuart Houston and his son, Dr. Stan Houston, are gracious donors for this evening's event. I understand their grandson, Adam, is also with them, so welcome to you. Ken Wilson, the Vice Provost of Faculty Relations-elect at the University of Saskatchewan. Firstly, I would like to welcome Dr. Ken Wilson, University of Saskatchewan Vice Provost, Faculty Relations-elect, to the podium to bring a few welcome remarks on behalf of the institution.
Thank you, Kara, and the Johnson-Shoyama School of Public Policy for inviting me here tonight to bring greetings on behalf of the university. Professor Stoichev, president of the university, is away, and so I got brought in his stead. So over the years, the University of Saskatchewan has made major investments in the future of health education and practice in Saskatchewan and beyond. We offer students one of the broadest arrays of health science programs in Canada and provide a strong foundation for undergraduate and graduate learning. And it's only fitting that the talk tonight, supported by one of our illustrious donors to the university, Professor Dr. Houston, is located in the Health Sciences Building, one of the largest capital building projects in the history of the University of Saskatchewan, and an innovative facility that offers a highly integrated experience for students, faculty, and staff, all in the healthcare fields. Here, over 1,200 health sciences related faculty and staff bridge across disciplines to promote and conduct interdisciplinary research to advance our understanding of health issues and to deliver interprofessional education that introduces leading teaching concepts in order to explore how best to provide clinical services that respond to the needs of today's patients. To be the university that the world needs, we must integrate education, research, policy, and practices to improve health outcomes for the diverse peoples of Saskatchewan, Canada, and indeed the world. We must also engage with and learn from leading thinkers, such as our speaker tonight, Mr. Picard. So on behalf of the University of Saskatchewan, I'd like to welcome André Picard back to Saskatoon, to our campus, and I would like to thank many of those in attendance tonight. I know, like you, I'm looking forward to the interesting discussions we're about to have. Thank you very much.
Thank you, Vice Provost Wilson. Next, I would like to welcome Doug Moen, the Executive Director of the Johnson-Shoyama Graduate School, to bring remarks on behalf of our school.
Thank you, Kara. On behalf of the school, I would like to welcome and thank all of you for attending and what promised to be an engaging and thought-provoking evening. Established through a joint collaboration between the University of Regina and the University of Saskatchewan in 2007, and with the support of our partnering institutions, government bodies, and community members, the Johnson-Shoyama Graduate School of Public Policy has carved out a national and international reputation that has attracted the attention of leading scholars, well-respected practitioners, and graduate students. This lecture, named after our gracious donors, Dr. Stuart Houston and his late wife, Mary, is a prime example of how we are facilitating dialogue and creating opportunity for evidence-based research in the areas of health, social, and economic inequality among all Canadians. As Kara mentioned, we are very fortunate that Dr. Stuart Houston and his son, Dr. Stan Houston, and grandson Adam are able to join us here tonight. So please join me in welcoming our donor and his wonderful family. An accomplished radiologist, Dr. Houston spent the majority of his career at the University of Saskatchewan as a professor and became the head of the Department of Medical Imaging in 1982. It was during this time that he made a name for himself studying the genetic origin of childhood disease. Now retired, he holds numerous honors, including the Order of Canada and the Saskatchewan Order of Merit, and has published extensively on topics as diverse as Saskatchewan's medical history, Canadian Arctic expeditions, and the birds of this province, one of his and his wife Mary's many life passions. As a reflection of their lifelong commitment to social justice, particularly as it involves health and income inequalities, the Houstons, along with their family, published the Houston Family Trust for Evidence-Based Public Policy at the Johnson-Shoyama Graduate School of Public Policy. With their gracious investment, we are pleased to host the second annual Houston Lecture, featuring the award-winning author and columnist, André Picard. We had the privilege of meeting with André earlier in the day, and based on our discussion, I promise you you were in for a treat tonight. So thank you very much.
Thank you, Doug. I now have the honor of introducing our 2019 keynote speaker, Mr. André Picard. André Picard is one of Canada's top health and public policy observers and commentators. He is the health columnist at the Globe and Mail, where he's been a staff writer for more than 30 years. He is also the author of 5 best-selling books, including his most recent, Matters of Life and Death, Public Health Issues in Canada, which received much acclaim for his writing and his dedication to improving healthcare. In 2010, he was awarded a National Newspaper Award as Canada's top newspaper columnist. André is an 8-time nominee for the National Newspaper Awards, Canada's top journalism prize, and in 2010, he was awarded as our country's top newspaper columnist. He is also the past winner of the prestigious Michener Award for Meritorious Public Service Journalism. Named Canada's first public health hero by the Canadian Public Health Association, and as a champion of mental health by the Canadian Alliance on Mental Illness and Mental Health, André received the Queen Elizabeth II Diamond Jubilee Medal in 2012 for his dedication to improving healthcare. He is a graduate of the University of Ottawa and Carleton University, and has honorary doctorates from 6 universities, including the University of British Columbia and the University of Toronto. Over the years, some of André's most compelling columns have covered a broad range of topics, including Canada's right to die law, the financial challenges of a publicly funded healthcare system, appalling conditions in First Nation communities, and the social and economic impacts of mental illness. I think we are in for an engaging evening as he provides us with his thoughts on mental health and addictions in Canada, and the need for us to move from an illness treatment system to build a true health system. Following André's remarks, JSGS's Dr. Cheryl Camillo, Assistant Professor and Director of our Master of Health Administration program, will join him on stage for the question and answer portion of our event. So please join me in welcoming André Picard.
Thank you for that very kind introduction. I see you got the email from my mom. That's great. She's very braggy. So I want to start by saying what a great honor it is to do the Houston Lecture, a very prestigious family supporting a very important event, and it's really a pleasure to be here. It's always a pleasure to visit Saskatchewan, but particularly to be on campus. So I have a confession to start off with. I prepared a talk well ahead of time. I did my duty and I prepared my talk. And then today I went and spent the day with faculty and with students, and they asked me so many good questions that I kept thinking, oh, I wasn't planning to talk about this, So I went back to my hotel and I rewrote my talk. So you're gonna get the more raw version tonight, not the second one, but if I see you falling asleep, I might switch over, but we'll see. So what I want to do in the short time I have this evening is talk about three things. I want to talk about the state of mental health and addiction care in Canada. I want to reflect a bit on the state of the health system more broadly, and then offer up some solutions. So let's start with drugs. Drugs are a really dominant and popular public health issue and a journalism issue in Canada today. I don't think anyone a few years back could have imagined that we would live in a world or in a country where drugs get more coverage than infectious diseases, a world where even casual readers know the difference between fentanyl and carfentanil, where the stodgy old Globe and Mail would post a how to roll the perfect joint infographic on its website, and in a world where reefer madness has actually given way to vaping hysteria. So there's a lot of stuff going on in the drug world. At my paper, we have more reporters writing about drugs than we do writing about sports. And there is some overlap there, let's be honest. And it's because drugs, like sports, are big business, both illegal and legal. So it captures the attention of the public. So I'm going to talk about drugs, though, mostly as a health issue, not an economic issue. The opioids crisis, or the overdose crisis, if you prefer, is one of the biggest public health challenges Canada has ever faced. More than 4,000 people died of overdoses last year alone. But there's a stereotype. There's a stereotype of people dying in the streets from injecting drugs like fentanyl. But that's only half the story. At least half of all the deaths are seniors overdosing on pain meds in their homes. Now, I don't like to frame it as an addictions crisis because people who die of overdoses are rarely addicted. And conversely, people who are addicted to drugs rarely die because they know what they're ingesting and they're injecting. People who use drugs for a long time are really good at titrating them, really going right to the edge but not killing themselves. So it's a complex field. Now, there is a crisis though. There's a double-edged crisis. And the solution to it is twofold. It's to ensure that people who take opioids for pain use them appropriately and at a safe dosage. We have to protect our grandmothers. That's a big part of it. Number two, we need to ensure that those who use drugs recreationally, and I use that term reluctantly, we have to ensure that they have a safe supply so that they're not dying inadvertently because they don't know what's in their drugs. And again, I just use that word recreational, but it's not the right word. There's nothing recreational, there's nothing fun about most drug use, especially the drug use that takes place on the streets or in dingy rooming houses. Many people who use drugs to the point of almost constant intoxication are self-medicating. And they're self-medicating psychological pain. I've met many, many street users over the years, and what they all have in common is profound trauma. Usually a history of physical or sexual abuse or being ripped from their families and sent to residential schools. And all too often, they also suffer from mental illness. It's not an easy group to help, but it's a group that desperately needs help. You can arrest them and you can jail them until the cows come home, and they're not going to stop. They're not criminals, they're sick and they need care. And that's where we should put our resources and our efforts. People who are sick deserve care and they deserve compassion, regardless of their illness, be it addiction, be it cancer, be it diabetes. We shouldn't make these false distinctions. And some of the most compassionate care we can offer is harm reduction. In Canada, we do a pretty good job of harm reduction. We've been late to the party, but we're catching up and we're very thoughtful and innovative in some of our programs. For example, we have supervised injection sites going on a couple of decades now. And as you may know, injection sites are where injection drug users can go for clean needles, for antiseptic surroundings, and medical help if they need it. And now we're broadening, we now now use the terminology consumption sites, because people couldn't smoke crack in these facilities, they can crush their drugs and ingest them. But the idea is to give them a safe space so they don't, if they do have problems, if they overdose, they don't die alone, because that's what kills you is being alone, not the drugs themselves. It's interesting to note that there's never been an overdose death in a supervised injection site. It speaks to their success. Thanks to clean needle programs, the rates of HIV and hepatitis have fallen sharply, because that's where infectious diseases begin and spread in the most vulnerable first. So they've been very effective public health programs. We have other harm reduction measures as well, like naloxone. Naloxone is an overdose reversal drug that works very well. It's available at no cost to anyone in most Canadian provinces. You can walk into a pharmacy, request naloxone, and take it home. And everyone who has an opioids prescription, even your grandma, they should have naloxone in their home, and you should know how to use it. I travel around the country a lot. Last week alone, I saw, just by happenstance, I actually saw 2 overdoses. One in the Ottawa airport and another on the street in Vancouver. It's shocking to realize how common this is. And when I work, I actually do carry a naloxone kit, and I think many people should, especially those of you in healthcare. Now, we also have drug substitution programs, things like methadone, Suboxone, and even prescribed alcohol and heroin. Not everyone is aware of these programs, but again, they're very effective. Now, the notion of giving people so-called free drugs, that bothers some people. It sticks in their craw. Why should we giving them stuff that they're just going to hurt themselves, they're going to harm themselves? But it's actually a thoughtful and a necessary public health program. I think one of the most important lessons of public health is to not be judgmental, to do what's right, not what necessarily makes you feel good. You have to deliver care without judgment. We should no more deny people with addiction access to safe drugs than we should deny people with cancer chemotherapy. Treatments come in many forms. Drugs are drugs are drugs. It's far more preferable to give people addicted to alcohol, alcoholic beverages, than to have them drink Lysol and hand sanitizer. And that, sadly, is the reality. It's far more sensible to prescribe people pure heroin than to have them inject contaminated street drugs that will see them ending up in emergency rooms, taking up the resources of firefighters, ambulance, paramedics. These are sensible economic policies as well as good public health policies. The reality is people have used drugs for time immemorial. They always have and they always will. Objections to drug use tend to be based more on moralism than on science. Now, some of you may remember this classic ad. You can still see it on the internet. An ad where there's a man holding an egg, and he says, "This is your brain." And then he points to a frying pan and crushes it and says, "This is drugs," and proclaims, "This is your brain on drugs." So, all drugs are supposed to scramble your brain. This is supposed to frighten you into behaving better. It hasn't worked so well, if you hadn't noticed. Trying to scare people straight has never worked, especially doesn't work for teenagers. Neither has prohibition. Prohibition is one of the most repeated and most failed policies in history. The so-called war on drugs, which has been going on for decades now, has been a social and economic disaster of immense proportion. Imagine if all the money we spent on enforcement was spent on social programs and helping people recover. Prohibitionist attitudes still exist, but these days they're a little more subtle. They come in the form of describing treatment as enabling, and by couching prohibitionist views in statements like, "Well, we just want to make sure everyone gets treatment." Treatment isn't for everyone. That's the reality. Now, I should say a word about the media coverage of drugs and addiction, because that's important. And I think it's pretty thoughtful. It's changed quite dramatically in recent years. I think we've adopted this more public health view of drugs, a more less judgmental way of coverage. But we still catastrophize a bit too much. We don't write enough about recovery, and a lot of people do recover. And a lot of people live their lives with addiction, taking their drugs every day and leading productive lives, and we forget that. But this neglect of recovery is a reflection of the fact that in our public policies, we don't invest near enough in rehab. We also have to learn to write about recovery with more sophistication. Recovery doesn't mean being clean or being sober. It's more sophisticated than that. And again, I don't like those words because they're judgmental, but I'm just using the terminology that's common. Recovery is about finding your sweet spot. It could be teetotaling for some. It could be drinking beer instead of pledge. It could be injecting at an overdose prevention site instead of alone in an alley. It could be going to a clinic and getting your injection of prescription heroin twice a day and then going back to work. And those are all stories I've written over the years. There's very few medical conditions that we actually cure. What we do is we manage them. We manage them by controlling their symptoms and by limiting patients' harms and their pains. And there's no reason we shouldn't do that with addiction, the way we do it with cancer or diabetes. We also need to put more effort into prevention. We have to wrap our heads around the notion that preventing addiction is ultimately about preventing childhood abuse and trauma and all the things that make people need to self-medicate. It's not about making drugs illegal, because that will never work. It never has. Now, I've spent a lot of time talking about drugs and addiction because they're hot topics and because they challenge our thinking, and I think that's important to do when you have a public forum like I've had the honor of having tonight. And also, I don't have to run for office, so I can say provocative things that are true, which politicians can't say. So I have to take advantage of that. But I want to switch the discussion a bit and talk more about the mental health side of the equation, about mental illness, both of which are very, very neglected. Mental health is often described as the orphan of Medicare, and rightly so. There are historical reasons for this. I mentioned that people have used drugs for centuries, but there's been mental illness as long as there have been people. Our stigma about mental illness dates back to at least to the Middle Ages. The behaviors exhibited by people with mental illness have often been treated as moral failings rather than medical problems. We've treated a lot of people with mental illness with religion rather than compassion. Now, because mental illnesses are invisible, they happen inside the brain and they don't show up, for example, as lesions on our skin. Because they're invisible, we've tended to see them as frightening. The brain is a frightening place when it's going wrong. People with mental illness often don't conform to societal norms, and that again makes them unpopular. So we've treated them as sinners, or worse yet, as criminals. And that isn't just ancient history. When Canada's Medicare system was fashioned in the late 1950s and 60s, we created public health insurance plans to pay for hospital and physician services. But an interesting footnote is that we left psychiatric hospitals out of the equation. At the time, they were called asylums. We decided they didn't belong as part of the Medicare program. And why is that? Well, they were considered part of the penal system, the jail system. That's how mental health patients were. They're to be locked away, never to be seen again. If you visit any old psychiatric facility in the country, I've visited many, they're always on the outskirts, hidden away, shamefully. Don't ever visit there. Eventually, because Medicare funded hospitals and stopped funding psychiatric institutions, they became run down. They became even worse than they had been. This led to a policy of deinstitutionalization, the closure of mental health facilities in mass numbers. In 1960 in Canada, we had 60,000 psychiatric beds. Today we have 6,000. We don't have any fewer people with mental illness. There's no question too many people were sent to hospitals then, but too few can get hospital care now. Deinstitutionalization is often explained as a civil rights initiative. That's a good positive spin on it, but the reality is that it was predominantly about saving money. And I'll say more about that a little later if I have time, but I think you know the ultimate results of deinstitutionalization because we see them on our streets, our city streets, every single day. The vast majority of people who live on the streets suffer from severe mental illness, about 80 to 90%. They're not there willingly, they're there because of their illness. And more often than not, they end up not only on the streets, but in jail, in this constant rotation of court, jail, streets, and back again, getting sicker and sicker every time. The ultimate irony is that we close these institutions and we patted ourselves on the back for it because they're no longer jailed. And today, they're worse off. Patients are worse off. They're in jail again, but they don't have nurses anymore. They have guards, prison guards. Jailing those who suffer from mental illness, like those who inject drugs, has absolutely no dissuasive effect and no therapeutic benefit. It makes no sense economically, socially, or ethically. Addiction and mental illness are the only medical conditions that routinely engage police, the courts, and the prison system. That should make us think about what we're doing wrong. We don't incarcerate people with diabetes for donut possession. We don't fine them when they fail to keep up a healthy diet. We don't arrest those who fail to exercise enough to bring their blood pressure down. But we do incarcerate thousands and thousands of people with addiction, even if they just possess a drug like cocaine or heroin, a drug that they literally need to survive. And we arrest and jail countless people with mental illness for antisocial behaviors that are part of their illness. Nuisance crimes like public urination, screaming loudly, loitering, shoplifting, and so on. Why do they do these things? Because they're sick, not because they're criminals. So we should ask ourselves, why do our encounters with those with mental illness and addiction lead to so little compassion and care? Because that's what's needed more than anything else. Jail certainly isn't needed. Court isn't needed. Fines aren't needed. The short, superficial answer to that is, in part, that we have a sickness care system and not a healthcare system. Healthcare is not just about waiting for people to get sick and then trying to patch them up. It's not just about giving them pills. It's certainly not about sending them to jail. Sometimes the best medicine we have is self-evident things. What do homeless people need more than anything else? They need a home. That's the best medicine we can and should provide. Now, I've alluded to this a few times in passing, but we have to get rid of this artificial distinction between physical and mental health, because there's no difference. You can have a brain disease the way you can have a heart disease or a liver disease. There should be no distinction. Someone with schizophrenia is no less deserving of care than someone with lung disease. Now, I want to delve a bit into what's wrong not only with mental health care, but with care more generally. But I like to use mental health as a launching point because it challenges our notions and our thoughts about how healthcare should be run. And I want to return to some history. I'm a big history buff. I'm really interested in the history of Medicare. And I think it's important to understand history because it helps us understand how we got into the pickle we're in today. And we do have problems. We have big problems in our health system, starting with waits. We wait for everything. ER, see a doctor, see a specialist, get into long-term care, home-term care. Everything is about waiting. We even wait at the Tim Hortons for our coffee when we come to the hospital here. It's in our DNA to wait as Canadians. So Medicare didn't fall fully formed from the sky. It developed over a long period of time in often quirky ways and based on our culture and our behaviors. Over these centuries, we've created this health culture that's unique to Canada. Waiting is just part of it. But the first hospital in what's now Canada was Hôtel Dieu de Québec. It was founded in 1639 by Augustine friars. 2 years later, Hôtel Dieu de Montréal was founded by the Sisters of St. Joseph. I actually live a couple of blocks away from Hôtel Dieu in Montreal. So for about 300 years, religious institutions and nuns, Catholic nuns in particular, dominated the delivery of care. Public funding of hospitals only began in earnest in the 1950s and 60s. Here in Saskatchewan, you got a jump. It was about 1946, so you got ahead of things. But faith-based institutions are still major players in the country today. There's a lot of crosses on our hospitals, and that legacy remains. The strong association between religion and health has had some lasting impacts. One of the main ones is this deeply held cultural belief that care should be free. We see healthcare in Canada as a charitable act, not as a business transaction. And in most of the world, that's how it's seen. So we have a very unusual view of healthcare, not necessarily a bad one, but a different one. It's not a coincidence that the father of Medicare was a preacher, Tommy Douglas. There's a really strong link there. The other institution that profoundly shaped Canadian Medicare was the military. The first state-funded health insurance programs were created for veterans of the First World War and their widows. Tens of thousands of men were left blind and with amputations from this very savage war, and we had to help them, so we created public insurance. Similarly, during and after the Second World War, we built hospitals and programs to care for the wounded. And at that time, the post-war years, a very heady time where we were rebuilding societies that were literally bombed almost to death, we built all these social programs, and we began talking about things like universal health care. Canada's model is very, very similar to Britain's. Prime Minister William Lyon Mackenzie King in this period spoke of the need for health insurance for everyone. He said it's the least government could do to thank Canadians for their sacrifices. So again, it has the roots in war. So aside from being religious and militaristic in nature, Medicare is also a political beast. So it's kind of a three-headed monster. Everyone here, of course, knows Tommy Douglas. He's a Canadian deity, especially here in Saskatchewan. You know why? His CCF government created the first public hospital insurance plan back in 1946, again, right after the end of World War II. Other provinces eventually followed suit. In 1956, the government of Louis Saint-Laurent offered to pay 50% of all hospital costs to the provinces on two conditions. One, that access to care be universal, meaning no one be turned away for lack of being able to afford care, and that user fees be outlawed. It's interesting historically that Tommy Douglas actually favored user fees. He thought people should have skin in the game. But those were the rules for provinces to get money, and they exist to this day. Now that law was adopted, that federal law was adopted March 1st, 1957, and that's essentially the birthday of national Medicare. Saskatchewan, as I mentioned, had a decade ahead of us. In 1960, Saskatchewan again blazed a trail. It expanded its public health insurance program to include physicians. The result, you know well, there was a big strike, but eventually the doctors came around, and now they're the biggest beneficiaries of Medicare, ironically. Best medicine we ever gave them. Now, 5 years later, 5 years after Saskatchewan's bold initiative, in 1965, Ottawa again extended this 50-50 funding deal to all the provinces, who didn't exactly jump on it. Medicare took a long time. We forget about this, that the last province to sign on to Medicare was Quebec in 1972, so it actually took 15 years for the program to come together in a semi-cohesive fashion. But to this day, that's what Medicare covers in Canada. It covers hospital and physician care. In legislation, we call these medically necessary services. And I should mention as an aside, I've mentioned this 50-50 funding deal a couple of times. Today, Ottawa only funds 21% of healthcare. So they've really reneged on their initial promise, and we don't remind them of that enough. But the premiers are actually meeting today, and their first demand at the premiers meeting today was more money for healthcare. But that's the most predictable thing on earth, but it happened again. Anyhow, you have to forgive me for going on so long about history, but I think the background is really, really important to help us understand today's problems. The single most important lesson to retain from this history is that the structure for delivering and funding healthcare that we have in 2019 is really fashioned on the 1950s, and very little has changed since then. Meanwhile, the world, from medicine to demographics to economics, the world has changed a lot. So have the needs of patients. The demographics is one of the most important aspects. In 1957, when Medicare was born, Canada was a young country. We were in the midst of the baby boom. Average age, 27. Life expectancy, only 67. And the health system delivered little other than hospital-based care for acute physical problems. So what did we do? We built a system for the people at that time. They need acute care in a hospital, and the notion of chronic care didn't exist. Today, the average age in this country is 47. We're one of the oldest countries on earth. Life expectancy is 82. The vast majority of our care is chronic care. It's a very different world. So what's wrong with healthcare in Canada today? In a nutshell, what's wrong with it is that we're trying to deliver 21st century care with a 1950s model of delivery and funding. We have an Edsel and we need a Prius or a Tesla or something, or maybe something that doesn't have wheels. I'm trying to be environmental, but I don't know. But I don't want you to get me wrong. I've been critical. That's my job. I write criticizing the health system for a living. But whenever I get the opportunity to speak, I always remind people that we deliver excellent care in Canada. When you're in the right place at the right time, the care in this country is second to none. And that's really important to remember. But the care is good in spite of the system, not because of it. We make it really difficult for our health providers to provide good care, and it shouldn't be that hard. Almost all the problems we have are administrative and engineering issues. We don't have medical problems in Canada. And unfortunately, what our waits tell us, what our frustrations tell us, is that a bad system beats good people all the time. So that's what we have to do. We have to fix the system. So that's what I just want to spend the rest of my time talking about. How do we fix it? How do we fix this out-of-date Medicare system that nonetheless delivers good care? How do we modernize the health system? How do we redesign it to meet the needs of today's population? People with chronic conditions, people with mental illness and addiction, things that we didn't talk about when our system was created, that we even shunned aside. We don't want anything to do with that. That's mental illness. We don't want that. Now, thankfully, we know the answer to the question. We know perfectly well how to fix our system. Every single problem in Canada's health system has been fixed at least 10 times, all in pilot projects, mind you, that never get scaled up. But we know the answer to everything, and that should give us some inspiration. Since the advent of Medicare, there have also been about 40 public inquiries and royal commissions and such that have studied the health system and made recommendations on how to fix it. If there's one thing Canada does better than any country in the world, it's study our health system. We're really experts at navel gazing. Now, implementation, not so much. That's the part we have to work on. And in these reports, I wrote a book a few years back about health reform, and I went back and I read all these major reports. That's how I know how dreadfully many there are. And every one of them, the first was by Mr. Justice Emmett Hall, again from Saskatchewan in 1964, right through to the famous Roy Romano report, 2002, another local boy, and so on and so forth. All of them have surprising unanimity in their recommendations. So what I did when I was writing this book, I had put all these recommendations from all these reports in a spreadsheet, and I was trying to make sense of them. And one night I had this epiphany, which was, in retrospectively quite self-evident, that they all say the same thing. All these reports say more or less the same thing, slightly different words for their time, but they have 6 major areas that say have to be fixed. So I'm going to talk about those. Number one, every report always says that we need to move away from our acute episodic care model to a chronic care model. We have to build a primary care system that's sound. You can't have a nice home if you don't have a solid foundation. And Canada doesn't have a solid foundation. We have 5 million Canadians without a family doctor. That's something that doesn't exist anywhere else in the developed world, is this notion of an orphan patient. So we have to get the basics right first. A medical home for every person so they have a central coordinating point for their care. Ultimately, someone has to be responsible for the patient or they're not going to be cared for. Right now, care is disjointed and people often fall through the cracks. If you're out east in some of the older hospitals, it happens quite literally, not just figuratively. We spend very, very little on infrastructure in this country. Again, that goes back to our religious roots, doing things like painting and putting chairs into hospitals. That's very seen as sinful. It's a little bit wasteful. And that culture still remains. And the reality is that almost all bad things that happen to patients happen in transitions. So the coordination function is really, really essential. Navigation is becoming a big topic in healthcare. It's where care has become so complex that that's where we have to focus, is helping people make sense of a system that makes no sense. We also need a front door for our system. The front door of Canadian healthcare is by default the ER. That's like going into your house every night via the fire escape. Doesn't make any sense. Need a front door. We have to deal with wait times. This notion of people waiting 48 hours in a hallway when they're 85 years old, that's barbaric and it's undignified and it's unacceptable. It doesn't exist elsewhere. Another essential element of primary care is having an electronic medical record. We don't have that. We have 1,000 different medical records that don't speak to each other. And finally, we're in the age of genomics, but we're still using fax machines. We've got to get into this century at least. Number 2, every report talks about the need to embrace community care. We need to treat people where they live, in the community, not just in institutions like hospitals and nursing homes. That doesn't mean getting rid of hospitals. That's not what I'm advocating. But you have to make their roles more specific and more clear. You can have tertiary care hospitals, ambulatory care hospitals, psychiatric hospitals. But this whole mishmash of everybody tries to do everything for everyone results in no one getting good care. We also have to build and staff our facilities appropriately and purposefully. And we have to do the same with community-based services. We spend a disproportionate amount of money on hospitals and not enough in the community. And these hospitals have no longitudinal responsibilities. Patients are released, and they're released more often than not into nothing. And unsurprisingly, they come back in worse shape. We have one of the highest rates of hospital readmission in the world, and that's usually a measure of poor care, readmission. So in Canada, far too much institutional care, too little community care. And nowhere is that more apparent than with mental illness and addiction. Number 3, every report, starting with the Hall Report in 1964, said, we must extend universal health coverage to prescription drugs. Sound familiar? That was written in 1964. It's one of the unfinished elements of business of Canadian Medicare. Currently, this is getting a lot of media attention, but about 30 million Canadians have some form of drug insurance, which means that about 6 million don't. And to me, that offends the very notion of Medicare, that no one should be denied care, necessary care, because they can't afford it. So we have to fix that, and we have to fix it about 50 years ago. But I want to stress that there isn't a single solution. Pharmacare doesn't necessarily mean a single centralized government program operated out of Ottawa. That's too much how it's presented publicly. But there are many ways to skin a cat. Different countries around the world have different models. The important thing is everyone has insurance that's affordable, and the details don't matter so much. Those who followed the pharmacare debate also know that there are many other issues, that publicly subsidized drug insurance is only one element. One of the most contentious issues is determining a formulary. A formulary is a list of drugs that are covered, and by extension, those that aren't covered. In Canada, we have wild variations in our formularies from one province to the next. If the provinces cannot agree on a formulary, we're not going to have pharmacare. That has to be job one. Another important element of pharmacare is regulation of drug prices. Having the state pay for overpriced drugs is not a solution. We have to have reasonable, fair prices. And we have to find the balance of allowing companies to make money, to innovate, but still get a fair deal for Canadians. And most of all, we have to ensure we get value for money, a good return on investment. And in Canada, we talk way too much about the cost of healthcare, the cost of drugs, and not enough about their value. Sometimes $1 million drug can provide good value, and $10,000, $50 drugs can provide very bad value. So we have to make that distinction. Number 4, and a very important issue here in this School of Public Policy, is every report has talked about social determinants of health and their importance. We need to invest in prevention, particularly for socially disadvantaged and marginalized groups, Indigenous people, those suffering from homelessness and mental illness, and so on. In Canada, we spend about 95% of our health dollars on sickness care and about 5% on prevention and health promotion. Really, we have a sickness care system. We don't yet have a health system. We also have to stop pretending that health is merely a medical issue. Education, housing, income, the environment, social connectedness, all these things are as essential or more essential to our health than medicine. Practically, this means that our health and social welfare systems have to be better integrated, not work at cross purposes as they often do today. And again, that's really, really true in mental illness. What many people need are housing and social supports, not more visits to the ER, not more hospital stays, not more time in jail. They need supports to live day to day. And the good news is we're starting to invest in things like Housing First initiatives, but they're too little and they're too late. We're late to the party again. Number 5 of all these elements that are in every report is health human resources. Healthcare is and should be a hands-on business. About 60% of all our health spending goes to labor, and that's not necessarily a bad thing. It's a people business. The problem is there's no coherent human resource policy. The number and type of health providers we have in Canada is based more on tradition than on science or on need. I'll give you one small example. In our aging society, the number of pediatricians has been increasing for a decade. The number of geriatricians has been falling. What kind of policy is that? It's nonsensical. We have to get the mix right of health providers and find appropriate and fair ways to pay them. And all providers need to work in teams and to their full scope of practice. That's the reality of care today is complex. It requires teamwork. And of course, if we want to improve health human resources, we need to change the way we educate health workers. And that's very important to say in this setting. There needs to be more team-based education and more hands-on education and less rote learning. By the time people between the time they start and graduate medical school these days, a lot of this stuff is not relevant anymore. We have to teach them how to learn, not just teach them stuff. Stop filling their heads with stuff and give them skills. The technological advances that are coming down the pipeline at breakneck speed, like genomics, artificial intelligence, robotics, deep learning, all these things mean that health workers have to be innovative and adaptable. The same is true of the health system writ large. And the final point that's in every report that always gets neglected because the other stuff takes our attention is quality. Every report has spoken to the need to emphasize quality over quantity of care. Canada, again, we obsess about quantity. How many hips did we do rather than did the right people who need them get hips? Those are very different questions. And quality, of course, is very difficult to assess sometimes, especially at an institutional or a system level. But we can do it if we put our minds to it. I write from a consumer perspective, so I like to look at quality in a different way. I like to look at it by asking a basic question, a really important question. What do patients want? Or more importantly, what do they need? And I've given a lot of thought to this question over decades, because to me that's the fundamental of everything we should be doing, should be answering that question. What do patients need? How can we provide it? And I think patients' needs can be summarized in a single sentence. There's a saying that the longer you have to write something, the more pithy it can be. Churchill famously said, I would have written a shorter letter, but I didn't have time. And that's true of many things. So over all these years, I've managed to boil it down to a single phrase, which I think is, if you remember one thing from my talk tonight, remember this. What people want is care that's prompt, affordable, necessary, safe, and respectful. I can't think of anything missing in that sentence. There's no reason we can't provide all those things to all people almost all of the time. There's going to be failings, but we fail in every one of those areas with far too much regularity. Think of your last encounter with the health system, as a patient, as a family member, as a health professional, as a bystander. Is that what you saw? Did you see care that was prompt, affordable, necessary, safe, and respectful? I would dare say there's very few 5-on-5s in the room. And that's what we should aim for every single time. And the final thing I'll say is you can't have quality healthcare without decent customer service. People don't like when I use that terminology, but that's the essence of delivering good care. That's what patient-centeredness ultimately means, providing what the customer needs when they need it in a pleasant fashion. The consumer revolution is upon us. It's already come to retail, it's come to transportation. We have Uber, we have Amazon, and the consumer revolution is coming to healthcare. And it's coming at a high-speed freight train. And I don't think we are quite ready to, and we don't quite realize what's going to hit us soon. And to me, that's the challenge for the next generation, is to undertake and embrace that consumer revolution and make those changes. And I'm going to end by quoting my great-great-great-grandson, the famous Commander Jean-Luc Picard, and I'm going to the young people in the room say, make it so. Because I'm getting old, we're getting old, and we need a better health system. So thank you for your attention, and I look forward to questions and comments. Thank you.
Wow, you certainly have given us a lot to think about tonight. I don't know if you could see me nodding in my chair, but I could see other people nodding as well. He said he thought I was nodding off, but I was very engaged in it. And so I'm really looking forward to the next portion of the evening. Thank you so much, Andre, for sharing with us your thoughts on where the healthcare system currently stands in Canada as it concerns mental health and addictions, and to your point, the broader health system at large. You've given us a lot to think about in terms of the challenges and opportunities we face to improving the coordination and effectiveness of services in order to better treat some of our most vulnerable populations. I would like to now invite Dr. Cheryl Camillo to the stage to moderate the question and answer portion of tonight's event.
Thank you, Kara. And thank you, Andre, for a very respectful and compassionate talk. You called it provocative, and it did provoke new questions that I didn't get a chance to ask you earlier today, and I'm sure it did in our audience's minds as well. I'm going to pose the first to you while asking any audience members with questions to come forward to the microphones. There's one here on my left on the landing and one on the right, and you can queue up and I'll alternate between microphones. My question to you is about solutions, that part of your talk. A few years ago, the Government of Canada struck bilateral agreements with each province and territory to invest in mental health care. $11 billion over 10 years for both mental health and home care investments. Can you tell us what you think about those agreements and those investments and what promise they have?
Yeah, so I think the problem with those, we see those type of agreements crop up, I'm sure purely coincidentally around election time, all the time. The problem with them is very simple. Where's the accountability? Where's the measurement? So it's easy to promise we're going to improve mental health care, but what do you mean? What do you mean, you know, chapter and verse, I want to know what you're going to deliver for $11 billion. And I don't have any evidence of that. So people say, do we get value for money for that? I have no idea. We didn't have anything to measure, we didn't measure it. So that's that happens time and time again. We had the famous Paul Martin invested $41 billion. He said it was going to be the solution for a generation. And there was zero accountability measures for that. None. So, I remember at my paper, we ran stories about how New Brunswick had taken its healthcare dollars and bought lawnmowers for the hospitals and stuff like that. Well, I'm not sure that's what it was intended for, and that's not accountability. So I guess I'm skeptical of those kind of things, and until I see evidence otherwise, I have to conclude that no, they don't work.
I'll ask one follow-up before turning to the first question. And again, I encourage audience members, any question you have about mental health care and the Canadian health system at large, please do come and take advantage of this opportunity to ask. My follow-up is, you're skeptical unless we measure provincial progress toward improving mental health care and access to mental health services. A couple years after the agreements were signed, the provinces and territories and the Government of Canada reached an agreement on shared health priorities and 3 measures. Are you skeptical and are you cynical? Is that not enough? Is it not fast enough?
Well, they're very vague measures, right? They're very, very vague. So I don't know. I like an approach, say, more like Sweden. Sweden has 10 public health priorities every year, and they're very precise. They're like, reduce child poverty from 2.1% to 1.7%. Very, very precise. At the end of the year, if they're not met, somebody doesn't get their bonus, somebody loses their job, there's actual consequences to not meeting targets, and that's what we need. I think people again get squeamish when I say this, but we have to run our healthcare system like a business. Mm-hmm. That doesn't mean a for-profit business, but it means a business. It means expectations, accountability, and fixing it when we don't achieve those goals.
Mm-hmm. Thank you for that thoughtful answer. Any questions from the audience?
Uh-oh, the lawyer's coming. I'm worried.
Adam.
Yeah, no, thank you very much for that wonderful talk. I'd like to come to your point about the freight train of customer service. And sort of particularly we can focus on, I guess, the mental health aspect of that. But in terms of customer service, perhaps the doctor isn't always right, but that takes us to the customer being always right, but also this new era where there is a pill for something, or I don't feel good. What service can I receive or demand that will make me feel better, even when perhaps that shouldn't be a commodified or a customer situation. I guess what's your thoughts on that?
Yeah, so you make an important point. The doctor's not always right, but the patient's not always right either. So in a public system, we have to ensure that we fund things that provide value for money and provide to the greater good. So I believe in consumers having power, but I don't believe they have a veto. And I don't think that, say every Canadian wants homeopathy covered, we still shouldn't cover it because it's nonsense. So you have to draw those lines. And one of the things we do worse, out of all our public policy failures, the one we do worse is saying no. So in Canada, we don't have really clear, if we have any parameters, they're not clear. So how do you get something new funded in Canada? The best way is to get your story on the front page of a newspaper, and then it gets politically micromanaged into the budget. That's not the way to run a business. I'm always harping on about if we want the health system to be better administered, we have to let our managers manage, and we don't do that. We second guess them politically. So we have to kind of depoliticize our system. Again, I always point to European countries. I think they do this much better. They allow their health, being a health bureaucrat in a country like France is a very prestigious job. You have a lot of power. The minister doesn't boss you around. You run the system and you're accountable for it. And that's how it should be. We should run it, let managers manage. So yeah, consumers have a say, but they don't have the ultimate say. A lot of people say, one of the most popular rhetorical phrases in Canada is, we should just spend all the money on frontline care and get rid of those bureaucrats. Usually doctors say that. And doctors are not managers. A lot of them are terrible managers. They can't even run their own offices. They shouldn't be running the healthcare system. So we need that combination. We need good medical care, but we need good administrators too, and they should each be doing their job well and in a complementary fashion.
The gentleman asked a great solutions-focused question, which is, you mentioned the 6 points that have shown up in report after report in Canada. He's wondering, what are the barriers to those being implemented?
Yeah, and that's a great question, because that's what I threw out my other talk, was about 20 minutes about what are the barriers to reform. So if I can remember them off the top of my head, I'll summarize. So there's a couple of big ones. So I think I'll start by the last one that I had in my talk, which is The public is one of the biggest barriers. So Canadians are very, very small C conservative. They don't like change. They're very fearful of anything changing because we've put out this public rhetoric about, oh, if we change anything, we're going to be the United States, and they're horrible. So we've got this big monster next door, this boogeyman, that allows us to do nothing. It paralyzes into the status quo. So that's one of the big ones. Politicians have also embraced that nonsensical view that the only alternative is the US system. There's a lot of alternatives. France, Netherlands, Sweden, and I don't suggest that any of those country systems could be imported whole hog because culture matters, but we can learn really important lessons from all of them. So the public is a big impediment. Politics is the biggest impediment to change. Joey Smallwood, Premier of Newfoundland, a father of Confederation, famously said, "I've never had a conversation about healthcare that didn't lose me votes." And that's really the attitude that prevails in healthcare today. Did any of you watch the federal election leaders debates? There is no section on healthcare. Single most important health issue in polling in Canada for the last 50 years, healthcare. Why is it not in the leaders debate? Because nobody wants to talk about it. And to a certain degree, there's kind of violent agreement among the parties. No one challenges the notion that we should have Medicare. I think that's not a bad thing, but it's a bad thing politically that there's no debate. So I'd love to see the parties debating those 6 points. I talked about fighting it out in the House every day. That would change healthcare pretty rapidly. Third one, really important one, is we have a lot of vested interests. And we have a combination of vested interests and no leadership. So the vested interests run amok. Nothing happens in our healthcare system if the Canadian Medical Association doesn't want it to happen. Now, they're not a bad group. Doctors are not bad people, but they have a self-interest that prevents us from doing a lot of things that we should do. Different kinds of health delivery, different kinds of payment to doctors. All these reforms just stagnate because power is not concentrated anymore, and there's a lack of, nobody who's in charge of the health system in Canada. Nobody. It just kind of putters on with no one in charge. So those are three big ones, and there are other impediments, but I think those are the biggies. Yeah, so essentially you're asking, how do we break the logjam, right? So how do we get rid of those things? And I think, unfortunately, the most likely way the logjam will break is some crisis. We're going to reach some tipping point where, the wrong person dies in the emergency room, and it always takes the wrong person, a celebrity, a politician or something, that's going to make this a scandal. And that's, unfortunately, in Canada, that's how a lot of policy changes. It changes because we have a scandal. Tainted blood is a perfect example, a topic I covered for many years. The drug system fundamentally changed. The way we compensate people fundamentally changed. Our legal approach to healthcare fundamentally changed. But at what cost? At the cost of 30,000 deaths. That's way too big a price to pay to bring about change. So, the other thing that can change it is leadership. Where's this generation's Tommy Douglas? I'm not sure. That's what we need. We need a figurehead, somebody that takes this ball and runs with it, even if it's politically unpopular, even if they're going to get attacked by every interest group in the country. That's what he did. He took on the doctors. He took on foreign interests. He took on insurance companies. I don't see anybody doing that. Our politics are way safer today than they used to be. And to be fair, they're way more difficult. Tommy Douglas didn't have to deal with Twitter, for example. Mm-hmm. But that's a reality. So it's hard to do, but I do think we're getting to a tipping point. And I think what's going to ultimately change things is millennials. I think millennials have a very different approach to much less willingness to tolerate just mediocrity. And that's what we have. And I often describe our Medicare system as islands of excellence in a sea of mediocrity. So we have a lot of good stuff, but we have a lot of just okay. And in this consumer revolution I'm talking about, this is led by millennials who are just like, I don't want just good enough. I want better. I want the best for me. They're a little selfish and self-interested, but that's not a bad thing. That's going to force us to do stuff and I think dramatically change. You know, once Apple's really investing heavily in this secret healthcare team. I know some people have been hired by them. Amazon's getting into healthcare. Apple's getting into it. What's his name? Buffett has partnered with Atul Gawande to change healthcare in the U.S., and this is going to ripple around the world. It's not just going to be the U.S. And, you know, we live next door to that elephant, and when it rolls over, we're going to get crushed too. I don't think people realize just how big a change is coming in the very near future.
We'll go to Doug Moen for a question, and then we'll move to this side.
Andre, thanks so much for your presentation. And just wondering what your view is of private sector delivered health services that have been traditionally delivered in the public system, and where you see it going from here.
Yeah, I always love that question. I think this, we have this weird paradox in Canada. We're very fearful of public healthcare, private healthcare, private delivery, and private insurance. We're fearful of it, but yet we're the country that has the most private healthcare and the most private delivery in the world, aside from the US. So it's kind of a weird combination. We hate private healthcare, but we have a lot of it. My view is that every health system, and I actually have a column on this tomorrow about private hospitals. So if you want to read my thoughts in more detail on private hospitals, they're in tomorrow's Globe. Please buy a subscription. My bosses say I have to say that every time I have a microphone. But I think that every healthcare system does and must have an element of private healthcare, just by the simple fact that a public health system cannot cover everything for everyone all the time. So by necessity, we have to supplement it. So the question for me is not whether we have private healthcare, it's where do we have it and how do we regulate it. So in Canada, we have the worst of both worlds. We have a poorly managed public system and a poorly regulated private system. We have really the Wild West of private healthcare. So we often, you know, people often say, especially proponents of private healthcare will say, why don't we do like Germany? Germany has a lot of private healthcare. And I say, yes, and Germany has really tough regulations. They don't mess around. They cap insurance fees. They fine you if you do unnecessary care. There's a lot of rules for private business. And so if we're going to have private business, that's what we have to do, is we have to regulate it well. I think the biggest failing we have in the public-private split in Canada is that we fund publicly 100% of hospitals and doctors. I don't think anyone believes for a minute that 100% of all physician care and hospital care is essential. I don't think it is. But at the same time, a lot of dental care is essential, a lot of long-term care, a lot of drugs are essential. Why aren't those publicly covered? So I often use the analogy of a basket. So we have a Medicare basket of services that's publicly funded. And right now we have this very narrow, deep basket with hospitals and doctors in it. And what we need is I really need to speak with two hands, I'm French. We really need this basket that's wider and shallower, that covers, you know, we should have public dental insurance. We should have public insurance for long-term care. We should have public insurance for drugs. But we don't have to cover 100% of it. Everyone should get the basics, decent care, and then you can supplement it. Now, the answer to that, is that unfair? You know, will some people get better care than others? Yes. But some people get better care than others now, and I think it would be much less unequal if we did it in a transparent, coherent fashion like France, like Germany, like Netherlands. I think that would make much more sense than the current mishmash we have now that was great in 1957 and it's not great today. Sorry for my rant, but one of my favorite topics for getting worked up about. So.
Yes, please.
Thanks so much for the talk. I really enjoyed it. I just was wondering, based on what you said about how many, other services that are provided that are essential for wellness that aren't necessarily part of front end, hospital care, do you see there being an issue with silos in maybe community groups providing those services, but being very separate from healthcare itself? And then how would you propose integrating, those community groups doing a lot of that work already, but aren't actually recognized by the healthcare system doing those things towards wellness?
So give me an example of what you're thinking.
So housing first it's not necessarily something that's seen as this is healthcare right here, but it is pretty essential to healthcare itself.
Okay, yeah, good. So good example. So I think The reality is that almost all of our care is delivered privately in Canada, but it's delivered by nonprofits. So hospitals are private institutions that are nonprofits. A lot of community groups work contractually for the system. So that's all good, but we have to do a better job, I think, of integrating across the silos. So housing is a good example. I always come back to this. I mentioned it a couple of times already. Homeless people need homes. It seems self-evident and almost stupid to say it that way, but that's, to me, a treatment for an illness, or a social illness called homelessness, is to have more social housing. So how do we fund that? Well, do we fund it in a Medicare type model? Do we do it with sporadic programs? Again, you know, there are inequities in how we deliver sickness care across Canada, but the inequities are 10 times worse in how we deliver social programs. So I think we have to have more standards. To me, that's the role of the federal government. The role of the federal government should be, A, to provide some funding to provinces, and demand in return that there be a semblance of a national system. And the way you create a national system in a confederate system is to create standards. And if you want your money, you respect the standards. If you don't want your money, you can do whatever you want. That has to be the role of the federal government, and they don't do that enough. That's what the Canada Health Act essentially says. It says if you don't respect these 5 elements, then we can withhold your funding. There's peanuts withheld. There's about $1 million withheld every year from the federal government on $40 billion. It's a joke. So there's no standard setting, there's no accountability for the provinces, essentially snubbing the Canada Health Act. The Canada Health Act's a paper tiger. It's largely meaningless. It's violated every second of every day in Canada. The worst aspect is portability. You're supposed to be able to travel anywhere in Canada with your health card and get care. Every province has a 3-month wait for care. Every province has, you know, if I live in Quebec, right near the Ontario border, if I try and cross into Ontario, no, you're from Quebec, you have to pay cash. Well, that's totally illegal, nonsense, but most people are not health writers who know that this is total nonsense, and most people are not equipped to fight back. So we have these violations of people's fundamental rights every single day in the health system, and that's Ottawa's fault.
Take a question from this side.
Thanks very much for the presentation and the conversation on mental health addictions and the implications for our healthcare system. I think it is for sure true that the healthcare system fails, particularly homeless people. If you discharge from an emergency room a homeless person to live back on the streets, it's akin to fixing somebody's broken leg but discharging them on roller skates. It's only going to lead to one outcome. But that speaks to the broader role for public health rather than the healthcare system in general. And that's something which has been progressively, since the Second World War, defunded. People realized how important it was, and since it was sort of marginally successful, stopped funding it. One of our problems is that it is much more attractive for politicians to fund primary health care in hospitals because A, special interest groups are campaigning for that. The public is asking for it. How do we as public health professionals persuade people that prevention genuinely is better than cure, and actually start to get politicians and the public to invest in it?
Yeah, it's a really hard sales job because as you know, we're in a public health school. You know that the paradox of public health is that when it works, it's invisible, right? So it's almost its own worst enemy. So you want more money, hope for a huge, deadly epidemic. That's the sad political reality. Otherwise, what do you do? I think I always talk, when I talk to groups about how to advocate to the media, how to advocate to politicians, I always say the number one thing you have to do is speak the language of the people you're trying to influence. So the language of politics is money. So the best argument that public health has is that it saves money. So you always have to come back to that economic argument. You spend $1 on early childhood education, you're going to get back $6 or $7 in economic benefit. So that you have to just hammer away. You can make those financial arguments for vaccination, for housing, for everything, and you have to keep hammering away. Now the reality, the flip side is that it's always going to be a better photo op to unveil an MRI than it is to be, you know, talking to a public health person who has nothing concrete to get you a picture with. That's always going to be a political reality, but you just have to keep hammering away at it and realize that, take some comfort in knowing that when you're successful, you're going to be the most ignored. So I don't know how to get around that.
No, I mean,
it has ever been so.
I think that is awesome. I mean, that is the big problem, and it's an awesome description of it. What do you think we can do with the media to change that discussion? Because for sure true, if there's a big outbreak, whether it's SARS or Ebola or influenza, we get media attention. They're very interested in the things that are done in public health to protect people. But how do we work with the media to actually solve things which are also a crisis, like mental health and addictions, and can't really be fixed without public health input? But the media attention is on the crisis aspects rather than the work which should and could be done to manage this in a compassionate way.
Yeah, so I think you can try working the media, but you have to realize too, it's not the be-all and end-all. There are lots of limitations to the media. You mentioned one of them. We tend to be very crisis-focused. So when there is a crisis, take advantage of it is what you have to do. That's one thing. Public health did a pretty good job of taking advantage of, say, H1N1, of SARS. So they got a lot of media attention. They got extra funding after that. So that was okay. Beyond that, how do we write health stories? We write about people. So you need those anecdotes. But again, it comes back to it's way more easy to write about someone who died of influenza than to find someone who didn't catch influenza because they got a vaccine. It's, again, I don't know how you get around that. It's harder to tell success stories than failures.
Thanks.
So we have to find, and we in the media struggle with that too. But I think there's been really good stories written, say, about housing first. People embrace that. We do a lot of good stories about harm reduction. So we'd write a lot about public health initiatives, but we don't, and maybe the best way is to not frame them like that. You frame them as solutions. We like to write about failures, and we like to write about solutions. So frame it in those terms, maybe.
Thank you.
Thanks.
We have 2 questions from this microphone, I believe.
Oh man, I always have to lower the mics. Thank you very much for your talk. My name is Sejal, and I'm a secondary medical student here at the U of S. And I think a lot of what you had to say really resonates with the younger generation of upcoming physicians in terms of preventative health care. And
I'm young at heart.
Absolutely, you can tell by the way you speak. I think upstream preventative health care is where we need to go in terms of dealing with overcrowding in ERs and the insane amounts of cost on our public system. And you have a lot of energy in young people, I think, and like you mentioned, you think millennials are I think we have the right mindset as well. So working, while we're med students and while we're working with the federal government that deals in 4-year terms, which is short, but we're kind of looking at the long haul here as future physicians, what advice would you give to young people who are maybe potentially going to be advocates for the healthcare system in advocating for a more upstream approach to health and preventative measures?
Yeah, so I think a couple of things is one is play the long game. Politicians don't play the long game. It's 4-year terms, but it's really 2-year cycles, right? So after 2 years, you start having to get reelected. So don't fall into that trap. Play a little bit of, short-term solutions are important, but you have to keep hammering away at the long game. So that's important. I think you have to try and retain your passion. Now, I don't want to put a damper on what you said, but the reality is young people in medicine have always been passionate, and the system beats it out of them. They get into the real world, and their ideals get crushed. The reality is they have to pay off their debt. Yeah, they have to pay off their debt, so they have to, swallow some of this pride and this passion and do the daily work. So it's hard to maintain that passion. So if you can do that, that's really the key. Now, the good side is I do see that happening. I see younger people in medicine and nursing. I see them more concerned about work-life balance, not working insane hours to pay off their debt and stuff like that, taking a longer view of that. And I think that's a really good sign that they're living their principles more and more. So that, I think, is ultimately what we have to do, is not only have principles, but live them, even if there's some personal cost to that. And there will be, there's no question. But that's ultimately the only way the system is going to change. Because the system, what does the system teach doctors? It teaches them, you have to work 100 hours a week, you have to be macho, you have to drive yourself into the ground, into burnout and mental illness and suicide. The system produces the exact results it was designed to produce. And they're bad results, which means it's a bad system. And that, we don't talk about that enough.
Thanks for that question.
Hi, so I'm a much older, but still not terribly jaded physician, and I guess this comment more so comes well on the after having heard what Sejal had to say. So I wanted just to speak and I guess argue with you somewhat in terms of physicians shouldn't be leaders or shouldn't be leading the healthcare system, or I know you didn't say exactly that, but for anybody in the audience and for people like me who are involved in being, I work at the Saskatchewan Medical Association. I am working with other leaders in terms of trying to advance the healthcare system in our province and in our country. And I would say for all of you who are interested in making changes, I think doctors should be there. Doctors should be there helping out. And I would say in our province, particularly, that's what I know, our infectious disease specialists, our addictions medicine people advocate tirelessly on behalf of good improvements of changes that will help people, advocate on improving the social determinants of health for our members. And I think we're stymied often by politics. And so just at the recent Saskatchewan Medical Assembly, Saskatchewan Medical Association Representative Assembly meeting, a number of great motions were forwarded to try and get universal contraception, for example, for which there's lots of evidence for, better sexual education teaching, which there's piles of scientific evidence for, and these were forwarded by physicians who want to be involved in leading the system and improving it. So everybody who is interested, who's a physician or a medical student, please keep interested, because I think we do need physicians involved in that.
Great. So if people retain the message that I thought politicians shouldn't lead, that's not my message. My message is that I don't think any change will happen without buy-in from physicians, so they're essential. Their leadership is really essential. But what I was trying to say is physicians should not have the final word. So they shouldn't be the only arbitrators, the only leaders. I think the voice of nurses is grossly underheard, for example, especially given their numbers. Nurses don't have the voice of doctors. They should, if not equal, they should have a similar one. The voice of PSWs, I think, is really important. But, personal support workers are some of the most important workers we have. They're abused, they're underpaid. They have a lot to offer. They work the closest and the most with patients. We have to get all those voices in. So I think physicians are really important, but they have a disproportionate voice. And to their credit, they use it, and they use it well as a cudgel. They use it to change social policy for the good, and they use it for their own self-interest, which is perfectly acceptable, but there needs to be some counterweight sometimes. So I hope that clarifies my position.
We have one last question.
Thank you for your talk. So I spent the summer in northern Saskatchewan doing suicide prevention, where I really got to see the lack of infrastructure and some of the health inequities up there. And so I'm just wondering, from a systems perspective, how do we start to address the health inequities, the lack of access to services, the challenges in funding? From a systems point of view, what needs to happen?
Yeah, so First Nations, Indigenous health, where do we start to correct hundreds of years of injustice, right? So that's a massive question. The Truth and Reconciliation Commission took a good poke at it. The section on health is really, everyone should read and memorize what actions we should take in healthcare, and I think that's the starting point. So what are their overarching messages about health? Essentially is that you have to, you can't solve problems without buy-in from communities. So you have to give more power to people to run programs, to establish the rules. You have to be culturally sensitive, etc. It doesn't mean that the mainstream health system just throws up its hands and leaves. Quite the contrary. It has to be there, and it has to be more present, but it has to be a little more or a lot less arrogant about it. Take some feedback. The suicide crisis in Indigenous communities, 5 to 11 times the rates of suicide of mainstream society in our Indigenous communities. We have to tackle the roots of that. That's the only way it's going to be solved in the long term, is the roots. So what are the root causes of suicide? Dislocation, sexual abuse, trauma, the trauma of residential schools, the intergenerational trauma. There's evidence now that trauma actually changes your DNA. This has had an impact on generations of people, especially in Indigenous communities where the trauma is so profound. The dislocation, the breaking down of the family structure. There's so many things to fix. Where do you start? I'm not sure where you start, but you have to recognize, I think you start with the kids. We have to, break that circle of destroying another generation. So we have to fix the next generation or give them the tools to not suffer the way their relations have suffered for 7 generations, as they say. So I think we could talk the whole evening about this, and there probably I hope you and I know you do have evenings on this topic here, but it's one that doesn't get enough airing or enough attention.
If I may, André, I'll encourage those in this audience as well as those watching from Regina to continue the conversation with you on Twitter at Picard on Health. Thanks, everybody, for your great questions.
So thank you so much, Andre and Cheryl, and everyone who asked insightful questions. I really appreciated the dialogue, and for me, what really resonated as somebody who's working in primary healthcare, your discussion about rebuilding the primary healthcare foundations and looking at the right door for people to access services. I'm positive that tonight has left us with much to think about. This concludes our lecture tonight. On behalf of the Johnson-Shoyama Graduate School of Public Policy, I'd like to thank everyone in attendance for coming out, and I'd like to offer you this gesture of appreciation for your time. Thank you.